Thanks, Werner. I'm going to talk to you about, I know the previous speaker touched on it a bit, the new immunotherapy treatments that are coming through, and we're already seeing them in the NHS. I think we're going to see a whole series of them over the next few years. I'm going to talk a bit about the immune system in general. I'm not an immunologist, so don't worry, it's going to be pretty basic. I'm going to talk a bit about the new drugs coming through, and perhaps also some of the implications for health services and how we work. I have had a bit of experience of working with these drugs, although I'm not a melanoma oncologist, which is where they're currently being used in clinical practice, at least predominantly in the NHS. I work as a medical oncologist at the Church Hospital in Oxford, and my main research interest is in experimental cancer medicines, and we're running a lot of early phase clinical trials of these drugs. So you've probably already heard about immunotherapy, because it's not just clinicians or academics that have got interested in this. The press has already made it a big story, and you've probably seen these I think this is from the Daily Mail, of course. I went straight to the Daily Mail because obviously I get that on a daily basis. Actually, for once, this health story is very exciting, I think. Although sometimes there is a bit of hyperbole, and I will touch on the problems that we are going to face with immunotherapy, and not just the potential benefits. It's actually not a new idea, immunotherapy. Paul Ehrlich, who was one of the fathers of modern immunology, German physician, he first put forward the concept of cancer immunosurveillance back in the early years of the last century, and he predicted that cancer would occur at great frequency if a patient's immune system or a person's immune system didn't survey for abnormal cells and kill them off. And since that hypothesis was put forward, we've seen lots of evidence within the last century, particularly in patients that have had immunosuppression, that confirm that theory. So we know that patients who are on transplant, who have had transplants and are on immunosuppressive drugs, have a much higher incidence of certain lymphomas. We know HIV patients have an increased incidence of sarcomas, some certain types of sarcomas, and also lymphomas. And we know that several infections are associated with cancer. One of the most common cancers worldwide, hepatoma, although it's not that common in the UK, is associated with hepatitis B and C infection, which is widespread in parts of Asia, and therefore there's a very high incidence of hepatitis B and C there. We've already touched on the hallmarks of cancer. I thought I'd do it again. Hanahan and Weinberg updated this, as we mentioned, only 5 years ago, and they added one of the hallmarks of cancer they added was avoiding immune destruction. That is perhaps a reflection of the interest in the immune system as a target for therapy. But again, actually, it's not a new idea to target the immune system. Several therapies have been tried in the past, and some are actually still in practice that use this approach. So BCG therapy for superficial bladder cancer is carried out on a routine basis in urological practices around the world, including in the Church Hospital. As you know, BCG is a vaccine for tuberculosis. And although its actual, the mechanism by which it tackles superficial bladder cancer is not fully understood, it is thought that it induces a local immune reaction when it is introduced intravesically by urologists. And it's very effective. It prevents recurrence in about 60 to 70% of cases of superficial bladder cancer, as long as you select your patients properly. Only a decade ago, there was a lot of interest, until about a decade ago, there was a lot of interest in a form of immune therapy that actually is now starting. There are more trials of this form of immune therapy going on now with the general resurgence and interest. But back about 10 to 20 years ago, there were a number of studies of interleukin-2, which is a cytokine, and doses of interleukin-2 were given to patients, mainly melanoma patients and patients with renal cell carcinoma. This cytokine promotes the expansion of lymphocyte populations, white blood cell, a certain type of white blood cell in patients, and also increases the activity of these lymphocytes, hence inhibiting tumour growth. And there were some interesting results with this treatment. Response rates are about 10 to 20% in renal cell carcinoma and melanoma, both tumours at that time that we really didn't have a good therapies for. And particularly interesting, there were durable long-term responses in some patients. So there was a handful of patients in these trials who had control over their disease for many, many years. The problem is that this treatment was very toxic for many patients. Many patients actually had life-threatening side effects, and some died from this treatment. And so it did have a restricted application. I thought before I talk about the new wave of checkpoint inhibitors that have already got into the clinic, it may be sensible for me to touch on how the immune system surveys for cancer cells at a very basic level, which suits me. I think in the sense of tumour surveillance, you can divide the immune system into two types: the innate immune system and the adaptive immune system. The innate immune system identifies tumour cells very early, so it's constantly surveying, as it were. And the main white blood cell that acts within the innate immune system is the natural killer cell. And this identifies cells within the body that may be infected or may be cancer cells that have an altered balance of proteins on their cell surface through a series of receptors that they've got on their own cell surface. And in the presence of an altered balance of these proteins on the cell surface, suggesting this is an abnormal cell, they will release granzymes and perforins, essentially proteins that will vesicles of toxic molecules that kill off that cancer cell or infected cell. The adaptive immune system, on the other hand, tends to react a bit later to abnormal cells, but is particularly important in terms of having memory for abnormal cells. And once it's got that memory, can be activated much more quickly. A key part of the adaptive immune system are the B lymphocytes, and when they come across new antigens, so not abnormal proteins, but proteins on the surface of cells that they don't recognize, they will release antibodies. And these antibodies can then bind to a cancer cell, for example. And one way in which these antibodies can lead to the destruction of that cancer cell is by attracting natural killer cells who will then bind to the antibody, releasing their toxic granzymes. But particularly that's the most important cell within the adaptive immune system with regards to tumour immunosurveillance, and this is the part that's targeted by the new checkpoint inhibitors, are T cells, which coordinate the immune response and are especially important also for destroying infected cells and cancer cells. So T cells have receptors on them. They will look for antigens, proteins on the cancer cells that not part of host, not thought that the T cell does not think the patient's own antigens. They will bind to these antigens and then kill off the cancer cell. And so what does that mean in the context of the new wave of immunotherapy drugs? Well, we know that tumour cells can mimic host cells in order to escape immunosurveillance. There's obviously has to be a complex system by which T cells don't just go around killing off every cell in the body, otherwise you would develop autoimmune diseases. But these checkpoint inhibitors allow the T cells to reactivate, having been deactivated by these the tumour cell mechanisms of hiding, as it were, from the immune system. So I'm going to talk a bit about now some of the new drugs that are now in the clinic and the ones that we're actually treating patients with currently, including on the NHS. So the first checkpoint inhibitor that came into the clinic was ipilimumab, which is a CTLA-4 inhibitor. Now, ipilimumab, so CTLA-4 in order to activate a T cell after it's stimulated by what's called an antigen-presenting cells, which identifies antigens, for example, on tumour cells and then presents them to the T cells so that they go off and kill the tumour cells. To do that, it needs co-stimulation by binding to CD28, a protein on the surface of the T cell. But if there isn't binding to CD28, because CTLA-4 is bound to B7, another protein. So I'm probably getting a bit technical here, but another protein on the surface of the antigen-presenting cell that inhibits the activation of the T cells. If you then bind an antibody such as ipilimumab to CTLA-4, this then once again allows the T cells to become activated and they can go off and kill the tumour cells. There's not much more biology in this talk, so don't worry. I'm glad actually myself. So. And the first study that registered this treatment for use in cancer cells was carried out in melanoma. And in this phase 3 trial, obviously already been through early phase trials. In this phase 3 trial, it was compared to the current cytotoxic or chemotherapy drug standard of care DTIC, which is actually pretty ineffective in melanoma patients with a response rate of between 10 and 20%, and patients usually relapse fairly soon afterwards. And that study, there's long-term survival data now, showed that overall survival for patients on ipilimumab was significantly better than for patients who are on the chemotherapy drug. It was actually in this trial combined with the chemotherapy drug in the arm of interest. That study was carried out in patients with advanced melanoma, but there's also been studies now in the adjuvant setting, so patients with high-risk melanoma who've had surgery with a high risk of recurrence have been given ipilimumab compared to placebo. And the current data suggests that there's a marked improvement in recurrence-free survival using ipilimumab in this setting. But the new set of drugs that have got everyone even more excited about immunotherapy and have just reached the NHS in the last year are the PD-1 and PD-L1 inhibitors. So PD-1 is a receptor on the T cell that binds to a protein on other cells, PD-L1. And this is one way in which tumour cells can deactivate when they bind to PD-1 T cells. If you use either a PD-L1 inhibitor to block PD-L1 or a PD-1 inhibitor to block PD-1 on the T cell, you can then reactivate the T cell and therefore get increased tumour cell killing. This was compared, the use of PD-1 inhibitors and PD-L1 inhibitors were initially compared with ipilimumab. This is a landmark trial of pembrolizumab, a PD-L1 inhibitor, versus ipilimumab, the results of which have been released in the last couple of years. And that shows that in terms of overall survival, at least up to about 2 years, pembrolizumab is a better therapy than ipilimumab. And on the back of all this exciting data related to the CTLA-4 inhibitors and PD-1 and PD-L1 inhibitors, the pharmaceutical industry and academia, I might add, have gone mad, and they are looking at all sorts of checkpoint inhibitors, both in terms of drug development and also now in clinical trials. However, checkpoint inhibition isn't the only immunotherapy strategy that industry and academia are looking at. There's a lot of interest in cancer vaccines. Here, cancer cells are removed from patients. They're then irradiated, and a modified gene is inserted into the cancer cell. The patients then receive these modified cancer cells, which and through this modification, they can be seen by the immune system and activate it, and that provides memory that the immune system then uses to go off and kill other cancer cells in the body, enhancing the immune response. There's a lot of interest in viruses and genetically engineered viruses as a way to hit cancer. One of these is TVEC. That's the one that seems to has got furthest through drug development. And this virus-based therapy infects tumour cells and replicates within them, but it can't replicate within normal cells. And when it destroys the malignant cells, it releases protein and antigens that allow the immune system to detect and gain memory of tumour cells, so it goes off and kills the other tumour cells in the body. A particularly complex form of therapy that isn't coming to a clinic near you very soon, but if you live near if you lived in San Antonio near the MD Anderson, then you might be one of 4 or 5 patients on a trial, is chimeric antigen receptor T cell therapy. Here, blood samples are taken from the patients, and they'll extract the T cells, and then they'll re-engineer them and administer them back to the patient. And these modified T cells then go off and recognise tumour cells and kill them. It's quite expensive. So why are oncologists excited about immunotherapy? I mean, I showed you those graphs, and it showed that in melanoma, they seem to be better treatments than chemotherapy, but chemotherapy doesn't really work in melanoma anyway. So admittedly, that's interesting and exciting in its own way. But this is the reason. It's because we're seeing maintained responses that seem durable. So I mentioned that so I showed in the previous graph and also here that it's actually only about 20% of patients that have good responses to immunotherapy. So that's still only 1/5 of the patients. But if you are living with melanoma, if you receive, this is the ipilimumab data, and we have data now for ipilimumab for about at least for 10 years, because the first trials for ipilimumab started about 10 years ago. And patients with melanoma, if they received ipilimumab and they were alive at 3 years, these patients all had advanced disease, you can almost guarantee that they'll be alive in 10 years' time. So we're almost talking. People are starting to talk about, is this actually a cure for advanced solid tumours. Now, outside of testicular cancer, really, we haven't ever talked about that at all with systemic therapies for advanced disease. And maybe we're now seeing the first systemic treatments that can cure cancer, which is remarkable. Although we still, oncologists, we're a bit touchy about talking about cure, but this is certainly a possibility. Well, I'll come back and talk to you in 20 years' time if I haven't retired, and we'll perhaps have another look at the data. But managing patients on immunotherapy, how does it differ from chemotherapy? So, these drugs do have side effects, and some of these side effects are very serious, or can be very serious. Actually, for PD-1 and PD-L1 inhibitors, typically they're generally very well tolerated, and we routinely give them to 70-year-old, 80-year-old patients, where you might be a bit worried about giving certainly a full dose combination chemotherapy, and these patients sail through it. But some patients do end up with a lot of problems, and CTLA-4 inhibitors in particular seem to be more toxic. Essentially, the side effects, as you might expect, are sort of autoimmune side effects, whereby the activated immune system goes off and kills healthy cells. The most serious side effects from immunotherapy, the ones or the side effect that can potentially kill patients, is colitis. That needs to be managed very aggressively, and I'll talk briefly about how we manage colitis in patients on immunotherapy in a minute. But it can have other nasty effects, which occasionally can end up as being life-threatening. So it can cause endocrine effects. It can cause pituitary damage. So some patients can go on to lifelong pituitary replacement therapy. That's not that uncommon. Can cause autoimmune diabetes, pancreatitis. We have to monitor patients' thyroid tests whilst they're on this treatment, and it's not uncommon to put patients on thyroid replacement. It can cause ocular effects, so you can get a scleritis or uveitis. Occasionally, patients can get a very nasty hepatitis that can even be life-threatening. Skin effects are very common, but generally not serious. So dermatitis, itch, vitiligo, alopecia are all quite common. This is a distribution of the mild side effects that are experienced by patients. These are all from the clinical trials for CTLA-4, PD-1, and PD-L1 inhibitors. As you can see, CTLA-4 inhibitors seem to be a bit more toxic than PD-1. Well, they are more toxic. It is a more toxic therapy than PD-1 or PD-L1 inhibition. But overall, the commonest mild side effects affect the skin and GI toxicity, so diarrhea typically. When we talk about grade 3 to 5 adverse events, so serious adverse events or death, again we see that ipilimumab or CTLA-4 inhibitors are significantly more toxic, and about over 10% of patients will get a nasty colitis on this drug that has to be managed very aggressively. In fact, in the original trials with ipilimumab, about 1 in 50 patients died on ipilimumab therapy. That's not the case on the recent studies because we're much, much better at managing side effects, and probably your chances of getting life-threatening side effects are certainly no more, provided you're managed by the right people, than no more than if you're on chemotherapy. But again, if we look at PD-1 and PD-L1 inhibitors, in terms of serious side effects, the profile is much better for those. The other thing about side effects related to immunotherapy, the time to onset is very different from chemotherapy. Usually, for cytotoxic drugs, we get a pretty good idea of how a patient's going to get on in the first cycle, 3 to 4 weeks. There can be late onset side effects with chemotherapy, and occasionally they can be serious, such as cardiac side effects, for example. But in general, you have a very good idea as to what the patient's going to suffer in the way of side effects in the first month. For immunotherapy, that's not the case. The median time to onset for side effects is about 60 days, so 2 months in. For a course of ipilimumab, you'd have already had your 3 of your 4 doses by that point anyway. And sometimes you can get these side effects very late on, so several months into the treatment. I thought, because we've already got patients on immunotherapy, not just in clinical trials, but within our NHS melanoma practice, and that might also may be the case, it won't be long before we have patients on immunotherapy in the NHS lung practice as well. I thought I'd just touch on the most serious, how we manage the most serious side effect, colitis, because it's possible that some of you will come across these patients. So, as I mentioned earlier, actually getting GI side effects is quite common on these drugs, or mild side effects. And if they've got grade 1 diarrhea, we can manage that with antidiarrheals. If they then develop grade 2 diarrhea, so over 4 or more stools a day, then really you need to get an opinion from an expert medical oncologist or a clinical oncologist who's got an interest in immunotherapy. That has to happen quickly. So you'd want to get that opinion within 24 hours, even if it's over the telephone. And you're probably going to want to introduce oral steroids at a high dose at that point. And you may want to get a sigmoidoscopy as well, urgently. If their diarrhea gets worse, goes to grade 3, then you're probably going to want to admit that patient. Certainly you're going to want to admit that patient if they're already on oral steroids, and you're probably going to want to give them IV methylprednisolone if they're already on oral steroids. If there's no improvement or the diarrhea gets worse, you need to institute infliximab urgently. So if things don't improve within 24 hours, you need to put them on infliximab. You may want to get back, rest the bowel, and institute TPN as well. If you don't go through this pathway relatively quickly, and we're not saying, what we're not talking about is if a patient comes in on Thursday and things are getting worse over the weekend, you wait till Monday. That's when patients really run into trouble. If you act like that, then you will have patients die on this treatment from colitis. The other difference between immunotherapy and chemotherapy, particularly in terms of perhaps our clinical practice, is that late response is common. And indeed, often we see the tumour get bigger initially before it then gets smaller. So this is a patient with melanoma, CT scan, cross-sectional CT scan of the lungs. We can see that there's a metastasis before treatment in the right lung circled, and actually after 3 months that's increased in size. So with chemotherapy treatment, certainly if you're just looking at that metastasis on its own, that was perhaps the only site of disease, you might say, well, this patient should come off treatment at that point. However, 10 months later, complete response, no visible disease whatsoever. So we actually have, certainly within clinical trials, we have a different reporting criteria when they look at CT scans to determine whether someone's responding or whether someone's got stable disease or not. This is another patient, non-small cell lung cancer, another cancer type that seems to be particularly responsive to immunotherapy. Nasty liver disease before treatment, pretty much a complete response at 15 months. And we often see these responses continuing over many, many months, sometimes even years. So how do we work out who should go on to immunotherapy? Well, actually, that's quite important, because although 20% of patients with advanced melanoma who receive ipilimumab do incredibly well, perhaps their disease will never come back, the other 80% don't really do any better than chemotherapy. And what we want to try and do is work out which of those 20% of patients who are going to do well, and which, perhaps more importantly, which of those 80% of patients who aren't going to do well, and develop treatment strategies for them. And that might, for example, involve combining immunotherapy with other drugs, perhaps other immunotherapy agents. So one way that has been shown to as a biomarker for response to immunotherapy is PD-L1, which you can stain for. You can look at the number of tumour infiltrating immune cells that stain positive for PD-L1, and also tumour cells. And we see that PD-L1 positive patients respond better to treatment than PD-L1 negative. But it's not a perfect biomarker by any stretch of the imagination. It's also the case that it seems that the number of mutations you've got in your cancer, how unstable your DNA is in your tumour, reflects the chance of you getting a response to treatment. So it seems quite clear that melanoma is particularly responsive to immunotherapy, but it also has a very high mutational burden. This is because if you've got a higher mutational burden, you're going to present more neoantigens to the immune system for it to attack. Lung cancers also seem particularly responsive. Bladder cancer, there's early data that suggests upper GI cancers maybe as well, stomach and esophageal cancer, and certain types of colorectal cancer seem to be particularly responsive to immunotherapy. So this is something we might be able to measure in patients, but it's not being done routinely at all, except in the setting of colorectal cancer. Now you can divide colorectal cancers into what are called mismatch repair proficient and mismatch repair deficient colorectal cancers. Mismatch repair deficient colorectal cancers have unstable DNA, and therefore potentially going to present more neoantigens to the immune system. And if we look at the blue lines, these are the mismatch repair deficient colorectal cancers, and you can see that they have much better responses to immunotherapy than mismatch repair proficient colorectal cancer. So actually the phase 3 trials that I've seen coming through with immunotherapy in colorectal cancers are just selecting patients with mismatch repair deficient colorectal cancer. But we need to do a lot more work to work out how we're going to select these patients, and in particular, we need to carry out clinical studies to determine biomarkers that will help us work out which patients aren't going to respond and those patients that will respond. In fact, I'm involved in a study at the moment in the setting of esophageal and gastric cancer, where we're going to be just doing just that. And these sorts of studies are going to be collecting white blood cells to look at their profile, collecting tumour samples for which we're going to sequence to look at the mutations and the sort of functional genetics of those tumour samples. And then also we'll be looking at protein with routine immunohistochemistry. What are we going to do with those 80% of patients who don't respond to ipilimumab? Well, the main idea is we're going to combine, most of the studies that are trying to increase the response rates to immunotherapy are combining immunotherapy with other drugs. And most of these studies are built on the pillar of PD-1 or PD-L1 blockade, because these seem to be better drugs than CTLA-4 inhibition at this stage. And so there are lots of trials combining these drugs with conventional agents such as chemotherapy, radiotherapy, anti-angiogenics. There are a lot of trials combining PD-L1 inhibitors, for example, with CTLA-4 inhibitors or other checkpoint inhibitory agents. And there are some trials that are combining this sort of immunotherapy with cancer vaccines and other more novel immunotherapy strategies. And this actually isn't up to date, so but you can see the number of trials combining immunotherapy with other drugs has gone from about 10 in 2010, and here it says it's gone up to about 50, but I can tell you now the last presentation I saw about 2 months ago at the AACR in New Orleans showed that there are over 100 clinical trials now combining checkpoint immunotherapy with other agents, and the number of studies is continuing to explode. And part of that is on the back of this data. So a year ago, almost to the day, at ASCO, a study was presented in advanced melanoma where they combined a PD-1 inhibitor with a CTLA-4 inhibitor and compared it with ipilimumab alone, so a CTLA-4 inhibitor, and they showed that response rates went from about, this demonstrates progression-free survival. So at 15 months, your chance of progression-free survival was about 50 to 60% in the combination treatment compared to 20% with ipilimumab. So a marked difference. This is a relatively small phase 2 trial, but very exciting data. But there is a drawback. Combining PD-1 or PD-L1 inhibition with CTLA-4 inhibition seems to have marked toxicity, particularly grade 3, grade 4, potentially life-threatening side effects. Your rates of colitis, for example, are reaching at much higher levels with the combination, and the same is the case for liver toxicity, which is far worse. Can we afford it? That's the other big question. Well, we are paying for these drugs at the moment in the setting of melanoma, but we know the cancer incidence is going up because people are getting older. These drugs, actually, when they're used as monotherapy, are well tolerated in older patients, so we will be using it in that population. We spent about 1% of GDP on drugs, significantly less than the US, which is about 2%. But we could, with the introduction of these sorts of therapies, we could see that percentage increase. And this just gives you an idea of the exponential cost of cancer therapies in general, which, if you see, really hadn't changed that much up to about 1990, and then in the last decade has increased dramatically. And Yervoy, which is one of the new checkpoint inhibitors, this is US costings, but it costs $40,000 US per month of treatment. So incredible cost. And when you think about combining these drugs, the costs are even greater. Now, of course, if you're only getting a 20% response rate, 80% of your patients will be off them quite quickly. So that's if you're a health economist, that's a good thing. But it makes it more important for us to be able to select patients appropriately, to make sure that we put them on the right treatment and don't spend lots of money on therapies that aren't going to work for them. We need to ensure that cancer services are ready for this as well. Many of you may have seen the NCEPOD report from about 8 years ago that showed that cancer patients, when they are managed in district general hospitals or perhaps within teaching hospitals but not by cancer physicians, often had very poor management, and that commonly led to high mortality and morbidity rates outside of expert oncology inpatient care. Now, it's actually the case that many oncologists really have had no contact with immunotherapy at all. So we need to train oncologists to start with. But we're going to also need to train general physicians to understand what to look out for, really when to pick up the phone if there's someone on immunotherapy that comes in with a problem to the oncology services. And that's going to be quite a big ask, because many of our oncologists have been treating patients with cytotoxic therapy for 30 years, and this is a whole new wave of treatments with a very different side effect profile and management as well. I thought I'd just finish off with a case study a patient who was treated in Oxford, not by myself, I might add. So Mark Middleton gave me this. This is a 56-year-old man who had an ocular melanoma, was first diagnosed back in 1989, treated with a radiotherapy implant at that point. Did quite well, actually. Ocular melanoma generally has a poor prognosis, but did very well because it wasn't until 2008 he had disease recurrence in his right lung, and he had a surgery for that. Certainly until recently, actually, surgery was the main treatment for melanoma. We just locked bits of people, lot metastases out of people when they recur. And it's a very effective treatment, actually, just surgical removal for solitary metastases in melanoma. And for this patient, that was an effective treatment because it wasn't until February 2013 he had disease progression with an intramuscular metastasis in the left psoas muscle and possibly a cardiac metastasis. And he went on to ipilimumab, the CTLA-4 inhibitor, which was available on the NHS. It still is and was then. But about 60 days in, his treatment was complicated by pituitary failure, a relatively common serious side effect of ipilimumab, and he had to go on to hormone replacement. But they continued the ipilimumab. However, approximately a year later, he had further disease progression in his left psoas muscle. So psoas is in the sort of hip area. And he was enrolled onto a trial of a novel immunotherapy agent that's called IMCGP100, which is interesting. That's been developed in Oxfordshire, actually, in Abingdon. It was developed in a company that grew out of a small ammo shed that they rented. But it's still a private company, but they raised $250 million about 2 or 3 months ago, which was the biggest European private equity raising of money that's occurred in the biotechnology sector. So it just shows the interest from not just patients and also academia, but investors in this sort of treatment. Anyway, so he continued. He went on to IMCGP100, but had disease progression later that year and was given radiotherapy to his psoas muscle metastasis. After that, he went on nivolumab, PD-1 inhibitor, as part of an expanded access scheme at that time. Had this drug every 2 weeks. After 6 cycles of treatment, had a CT scan, stable disease essentially with a minor decrease in the main target lesion we were measuring. He's tolerating treatment without any side effects at all, unlike the ipilimumab. Continued on treatment in February 2016, remained well, had a continued minor response. So, a few discussion points from that case study. He's had several different immunotherapy agents, so you can give one, they can relapse, you go on to another, and they can get excellent responses from a different immunotherapy agent. With the nivolumab, he had an ongoing response. With the ipilimumab, you only get 4 doses, and he had an ongoing stable disease or a minor response many months after he stopped the treatment. Not something you typically see with chemotherapy. If you manage the side effects properly, you can often continue patients on immunotherapy. An ocular melanoma, which traditionally has been seen as a disease site that is very difficult to treat, does seem to respond to immunotherapy. So in summary, immunotherapy is not a new idea. The idea of immunotherapy has been around for at least 100 years. There's many different types of immunotherapy being assessed, although checkpoint inhibitors are the ones there's greatest excitement about and the drugs you're going to be seeing in the clinic. These drugs deliver long-term durable responses, but only in some patients. But it's possible we're talking about cures in those patients, and that's why these drugs are so exciting. We need to understand how to select patients. to make sure that we select the right treatment for them. And also, actually, we need to actually understand how to select patients in terms of whether they're going to get the nasty side effects that you can see with the drugs. For those patients that perhaps are less likely to respond to monotherapy with the checkpoint inhibitors, we're going to look to see if we can combine treatments with immunotherapy to improve the response rate and improve overall survival and quality of life, of course. And we actually don't really understand what to give first. Do we give ipilimumab or nivolumab? At the moment, we tend to give ipilimumab first. I think that's because that's what NICE tells us they'll pay for, but that doesn't necessarily mean that's the right thing to do. But studies need to be done to perhaps understand that. It probably doesn't matter, to be honest, would be my opinion. But would matter if you could select patients, of course, to receive the right treatment. The side effects are often different, and they're often late compared to conventional treatments. And we need to gear up cancer services so they can deal with these side effects, because if they're not treated properly, they can lead to life-threatening consequences very quickly. And the cost of these drugs is going to put a significant burden on cancer, not just cancer services, the healthcare system and the country in general. So I'm happy to take any questions.
Thanks, Simon. That was really interesting. So Susan's got the roving mic, so I see lots of hands going up. So Liz, perhaps if you could.
Yeah, just to reiterate that prior to giving these treatments, it's the blood test that we need to do. And unlike traditional chemotherapy, where we like the blood results to be within 24 hours prior to the classic drugs, that with the immunotherapies, we can have a longer treatment, a longer delay, but also it's more we're looking at the sequential results. So it's looking at the results like your thyroid function tests, making sure we've got them at baseline, glucose, and anything else particular to drugs. So it was just to reiterate that.
Yeah.
To doctors mainly, is that right?
Nurses. I think the problem is that with our traditional chemo, historically we look for blood results within 24 hours. Yeah. And I think our issue we have as we bring out these drugs into the NHS and they become standard, it's what results do we need and how old can they be? And so what we find in clinical practice is we can have results up to a week old, because it's not affecting, like your full blood count. It's not affecting neutrophil count as much as the traditional
And I think
drugs.
you made a really important point, Liz, about the need to look for sequential results for thyroid function, liver function, and so on. But historically, with conventional cytotoxic drugs, we would have looked for the last 72-hour blood tests. So. Nicola.
We were talking about the 100,000 genome project after the first speaker, and you were saying that some patients that we might be able to target these new treatments to may be those with more mutations in their genome. So do you think that in the future we may be actually testing individual patients for mutations in their genome and then targeting these treatments to those patients? Potentially.
In some ways, it's perhaps more about. I suspect it'll be more about the instability of the DNA in general, and there might be simpler tests. There are simpler tests to do that. So that's in Oxford routinely. We see if patients have got mismatch repair deficiency. So that happens routinely in NHS practice. Admittedly, it's not paid for by the NHS because it's part of an academic program, but we do routinely do that. And it wouldn't be and I'm certain that test will become. I'm fairly certain, given the early data, that we'll be giving only colorectal cancer patients who are mismatch repair deficient these drugs, and I'm certain the NHS will want to pay for that small cost of that test, so they select those patients properly for those drugs. So I think some of those tests are already there, as it were. But I don't know if it's difficult to know whether individual mutations are going to determine response. That would be unlikely, I think. Obviously, that's may well be. It's almost certainly going to be important for other targeted therapies, but not necessarily checkpoint inhibition immunotherapy.
Simon, can I just ask you, following on from that? So, when with Peter Risby last year, we did a audit of the mismatch repair referral protocol for patients with primary colorectal cancer that had a surgical resection. there was an upper age limit in terms of eligibility for that testing, which was 70. And then on the oncologist's request, some patients over 70 would be tested, but that wasn't within the referral protocol. So given the population you were talking about, well, what are your thoughts about, what should a referral protocol include in terms of eligibility? Should we not have an age eligibility criteria for this patient group?
Well, at the moment, we aren't using immunotherapy outside of clinical trials for colorectal cancer, so it probably wouldn't affect clinical decision. Well, I'm not a colorectal cancer expert, I must say, but I don't think it would affect clinical decision making or very important clinical decision making at the moment. But obviously, if you're going to use these immunotherapy drugs, and this seems to be a very good way of selecting patients, I'm sure that that test will be used in all patients.
Yeah, I mean, because at the moment the test is made to say, do we use conventional cytotoxics or not?
Sure, I get. Yes, what we're talking about is adjuvant, because it's using. You're talking about adjuvant treatment, aren't you, in the colorectal cancer setting? So there's a lot of debate about whether you should use adjuvant treatments in certainly very elderly patients. Because we know that this is cytotoxic therapy. We are going sort of off on a different tangent here, age concern would have one view, and then other people would have another view. The issue is with cytotoxic drugs, the pharmacokinetics are different in older patients. We know that they don't tolerate them so well. We know that if adjuvant treatment is going to have less of a beneficial effect in someone who's 85 because they're unlikely to live to 100. But if you're 45, if you survive that instance of cancer, you might then live to 85. So the benefit of a drug that could kill you and has a higher risk of killing you, probably it's almost certainly if you're 85 is different. So I suspect that's one of the reasons why they're not using it to make decisions on adjuvant therapy in the clinic. But I'm not involved. I haven't been involved in that discussion at all, so I couldn't really comment much further than that.
But if we were to move towards, say, targeting things like PD-1, PD-L1 in tumour groups like colorectal cancer, then
there you would, because these drugs are very well tolerated in older people. Some of the combinations, CTLA4 inhibition and PD-1 inhibition, where you've got 20% of patients getting life-threatening colitis, or 10% of patients getting life-threatening colitis, you might not want to use that in the older age group. I think I would be quite worried as an oncologist trying to manage those patients. But certainly monotherapy, PD-1, PD-L1 inhibition is very well tolerated, and we are routinely in clinical trials treating patients 70, over 80, sometimes over 80 with these drugs, and I would have no concerns about treating them with that therapy. So in that case, then you're going, if you've got a good biomarker, you should definitely use it.
Other question. So this is going to come up from microphones.
I was just interested that the patients with severe colitis you're treating with an anti-TNF. I work in rheumatology, and we don't give any patients who had a previous cancer any anti-TNF at all.
Yeah, by the time you're using that drug, which is very effective in this case, the patients are at death. If you don't do anything, they're probably going. There's a good chance they'll die. So you make that decision. So,
Using it, starting to use it as well in patients with ulcerative colitis and Crohn's disease as well.
Yes. Okay, thanks. Yeah, Lottie?
Is there a time limit or dose limit for these drugs, like with the gentleman in the case study? If the nivolumab's working for him, would he just continue to have that if it's working for him? There's not a...
No, that's a good question. So ipilimumab, all the studies just gave 4 doses, so you'd stop after 4 doses. To be honest, the clinical study, we don't really have the clinical data to determine how long we should give these drugs for, or have certainly no phase 3 data. So a lot of it's based on tolerability and guesswork. PD-1, PD-L1 inhibitors are usually given up to 2 years, but if patients have alive at 2 years and essentially responding, then they will stop it at that point. And it seems that the immune system then just kicks in, and you get a bit like ipilimumab. Although you only have the treatment every 3 weeks, 4 doses, 20% of patients' cancers will continue to respond even a year, 2 years later, and in 20% of patients they'll still be alive 10 years later with no sign of cancer. So you don't need to continue the drugs, it seems, to maintain response or get an ongoing response.
Right at the back. Hang on a moment, we'll bring the mic because otherwise we won't hear you.
And to check that it's still working.
Routinely 3 monthly. Obviously, if you've got concerns, you might it's not an exact science, but routinely 3 months. In the trials, it's more regular. So.
And just following on from that, I think it's really important, as Simon mentioned about this interval tumour progression, so you can give the treatment and then the tumour can get larger. And if you think that patients having melanoma, if they've got metastatic cutaneous lesions and then they see those tumours getting larger, it's really important. We know that actually you get the treatment and the tumours can get larger before they then do start to reduce in size, because that could be quite alarming, I think. I mean, I don't know what your thoughts were about that.
That's good. So yeah, that's a good point in some ways, because say you saw the tumour getting larger at 3 months, and you weren't sure if it was progression or actually maybe possibly inflammatory response, you might then repeat your CT a bit earlier after that. I think if someone's responding at 12 months, then you're probably not going to do CT scans nearly so often. But initially, typically, we do it every 3 months. It's kind of, there's not an exact answer. You do it depending on the clinical need.
I think that's it. So once again, thanks very much, Simon.